We have reports out in this country from supposedly serious medical experts calling for Canada to essentially have a drug free-for-all in this country. Hello, my name's Brian Lilly. Welcome to the Full Comment Podcast. And one of the issues that we want to delve into today is how we went from having discussions about safe injection sites and how we can help addicts consume drugs in a safe area to literally handing out thousands of heroin pills and then calling for crack and fentanyl to be made legal and sold in stores and distributed by compassion clubs. That is where we're at in this country. And there hasn't been much of a debate. This is just what the health experts are telling us we must do. Adam Zivo has been at the forefront of reporting on issues surrounding safer supply, or in reality, let's call it what it is, unsafe supply. He's been writing in the National Post, occasionally in the Toronto Sun, and he is the founder and executive director of the Center for Responsible Drug Policy. He joins me now. Adam, let me start there. How did we go from, hey, let's have a safe injection site out in Vancouver to let's hand out hydromorphine pills like it's a Pez dispenser?
Well, it all comes down to the radical harm reduction movement, which has been advocating for these changes for over 2 decades at this point, right? You have this well-organized, very entrenched movement, which piece by piece kept pressing the envelope with the ultimate goal of drug legalization. And now they've almost achieved that goal, though thankfully there's a big public backlash, which is thwarting them because we are seeing the social costs of their radical experiments.
But we've been sold at every turn that, well, if we do this, such as safe injection sites, we will have fewer drug deaths. And nobody wants to see drug overdose deaths. And most of us have had to deal with this sort of issue, addiction, somewhere in our family, in our circle of friends. And so Canadians, being nice people, have been, okay, well, I don't love the idea, but okay, let's go forward. And yet drug deaths have not gone down. I'm looking at British Columbia's BC Coroner's Service report, and they keep saying this is working. I'm not sure how. Perhaps math was not part of the equation to become a coroner. But the number of overdose deaths went from 370 for the total year in 2014 to 2,558 last year. And it's almost a straight line up. There was 1 year when things went down. That was 2019, but from 370 to more than 2,500. And so far this year, we have seen more, actually more than double 2014's number between the beginning of January and the end of April. In 4 months, we're now seeing double the overdose deaths. At some point, doesn't it don't you clue in and say, this isn't working?
You would hope, but there are other factors at play that they tend to blame this on, some of which are legitimate and some of which are not. So we have to acknowledge the fact that fentanyl did come in and change the game. 10, 15 years ago, fentanyl was negligible. I mean, people didn't use it, and it's 50 times stronger than heroin, and slowly it seeped into our drug supply. Much more addictive, 50 times stronger, and it's much easier to overdose and die on it. So yeah, it's entered our market and it's entered the US market as well. And as a result, deaths are skyrocketing in all jurisdictions. So it's okay to say that these deaths are caused by fentanyl in a large respect, and that we shouldn't blame harm reduction for all of this chaos. At the same time, you can also believe that harm reduction radicalism has been remarkably ineffective at addressing these increased harms and has exacerbated these harms to a certain degree. So you can accept both things. You can say, yes, the increasingly deadly illicit supply is a factor, and also harm reduction is making things worse. The harm reduction activists, though, refuse to acknowledge that they may have made things worse, and they say that it's just the illicit supply that is to blame, and that if there hasn't been any sign of success, that doesn't mean that harm reduction is not working in their eyes. It means that we just need more of it. We need more liberalization, we need legalization, and we need more safe drugs. It's insane.
This sounds like the people that defend communism by saying communism's just never been tried right. It hasn't been done right. And I would point out that everywhere communism has been tried, it's led to oppression of basic freedoms, whether we're talking Cuba, China, East Germany, Eastern Europe, the former USSR, the only way that those structures continue to operate is with repressing personal freedoms. And but the diehards will say, well, no, we just got to try it again. And that's what it sounds like with the harm reduction folks. Well, this didn't work, so we have to do more of it.
And that's the thing, right? Is that if you're going to engage in an experiment, you have to have a testable hypothesis. Your hypothesis has to be possibly false, right? Uh, and what they're essentially saying is that we have this hypothesis that harm reduction works, but we refuse to accept any evidence that our hypothesis is wrong. And so at this point, you're not actually engaging in science, you're engaging in an ideological experiment that goes all the way and cannot be disproven in your eyes.
So, look, I accept what you're saying about fentanyl coming in, and that really took off around 2016. And not in all parts of the country, but in some parts of the country, it showed up later, but around 2016. And you can see a definite jump. 2016, British Columbia had 996 overdose deaths. The next year, 1,500. The year after that, just a few more. Then it went down. And since then, it has just been on an awful trajectory. We went from 7.9 overdose deaths per 100,000 to 46.3. This year, we're on track in British Columbia for about 40.3. British Columbia has been at the forefront of this push for drug liberalization, for trying new harm reduction methods, both in terms of where their public health mindset is at, but also in terms of court challenges, like the Portland Hotel Society for Insight. So, they've been at the forefront of this. And we've got provinces, or thankfully not the government, but people like Dr. Kieran Moore, who's the chief medical officer for the province of Ontario. He came out in March with a report saying we needed to go in BC's model. And he also pointed to Oregon, which recently backed off decriminalization. He wanted full decriminalization. He wanted to embrace the safe supply, which already exists to a small degree in Ontario, not as big as British Columbia. And my view is, if British Columbia has 1/3 of the population, but they have more overdose deaths, to me, that's just a non-starter. That is the proof point that this is not a model we should follow.
And I think any reasonable person would agree with you. But once again, public health officials are not responding to evidence. They are not advocating for evidence-based policy. They have a goal. Their goal is drug legalization, oftentimes, and they are willing to relentlessly pursue that goal regardless of the inconvenient facts that pop up. What I thought was really interesting with Kieran Moore is how he cited Oregon in positive terms, despite the fact that it's very well known that Oregon's decriminalization experiment was a complete disaster. It led to a horrible breakdown in public safety, right? And while he was citing BC as an example of success, we saw the same thing there with a giant public backlash where families just didn't feel safe in their cities anymore. They hated the fact that when they went to playgrounds, they would often find syringes, and the BC NDP was forced to renege on decriminalization less than a year after implementing it. So how is it that someone who is, a leading official, a leading public health official in Ontario, can look at these two jurisdictions and say, that's what we want to do? I would highly question the trustworthiness of that kind of official, of their competency.
Well, Dr. Moore, by comparison to some other medical experts, he was appointed in the middle of the pandemic. He seemed much more steady of a hand than his predecessor here in Ontario. He also was, he seemed like he was trying to look at the evidence and not just go with whatever the latest thing that some doctor was screaming at on the all news channels. And seemed reasonable in that. And so I thought, oh, okay, interesting fellow. I'm not agreeing with all of his recommendations on COVID, but interesting. And at least he appears to be thinking and thoughtful. Mm-hmm. With public health officials, it seems like harm reduction taken to the extreme is an article of faith.
Mm-hmm.
I'm a Roman Catholic. I could sit here and recite the Nicene Creed. Now, can I prove everything that's in there? No. Why? But so why do why do you say it? Because it's an article of faith. It is faith. It is religion. It is not science. It is not proven. They seem to be operating just like a Catholic at church on Sunday, a Jew in synagogue at the synagogue on Saturday, a Muslim at the mosque on Friday.
I think that's a fair assessment. And one thing that I do want to point out here is that our addiction policies are primarily driven by public health officials. There's this public health approach to addiction. But let's be honest, public health officials are not necessarily addiction experts. People who work in addiction medicine, including addiction physicians and addiction psychologists, are the experts here. They are the ones who are experiencing this crisis on the front lines and are seeing at the clinical level what's going on. And these experts are the ones who are saying again and again that what we're doing is not working, that safe supply is being diverted, that it is dissuading people from going into recovery. And yet their voices aren't listened to because the public health experts now have the microphone. And I think, we should remember that public health, it's not a scientific degree, right? It's kind of, it's a social science. It's far less rigorous than addiction medicine. So we've given
friends who are doctors keep making the joke that you end up in public health because you were at the bottom of your class.
Exactly. And look, some of our top public health officials do have a medical background. Kieran Moore has a medical degree, same with Dr. Bonnie Henry. But so many of the people who staff the bureaucracy do not. And so they have a really weak educational background compared to a medical official. They don't have any strong background in addiction, and yet they have taken it upon themselves to dominate addiction policymaking, which is why we have the problems that we have today.
I'm going to read you a portion of an email that I received from a resident that lives near an area where they have both a safe injection site and a safe supply program. It's in Toronto's Dundas and Sherbourne area. Mm-hmm. It's economically not a great area, but there are families living in nice houses on certain streets, and they were getting along just fine. And then these programs moved in. And what are they dealing with? The complaints include walking your kid to school and them being exposed to seeing vaginas and nipples, a man urinating with his exposed penis, violence, vulgar language, threats, aggressive panhandling, people passed out blocking the sidewalk, and harassed by unstable people. This same gentleman emailed me a while ago photos of what he saw just trying to leave his garage at the back end of his house. Sex acts being performed in the middle of the laneway where all the families park their cars, where they store their garbage cans when it's not garbage day, that sort of thing. Your kid's going outside to play road hockey, and there's people trading sex for drugs. These are the harms that go beyond the harm of the addict. But this is what people living in the neighborhoods where these facilities are set up have to deal with. And I've talked to many of them, and many of them are, they're dismissed as right-wing cranks who don't want to help addicts. And they're not. They're very nice, lovely people, many of them quite progressive in their politics, but they're looking to their city council. They're looking to the medical officials that run these places and saying, you have to deal with this mess because this is not what my children should be seeing on the way to school.
And I think that is very true. And I hear these stories all the time from people who are living near these facilities and are experiencing really horrific breakdowns in public safety. The problem here is that the bureaucrats who oversee these programs, or fund them rather, and regulate them, do not live in these neighborhoods. They often live in nice, safe, relatively wealthy, relatively white neighborhoods farther away from downtown cores. And so,
the types of places where they would never approve that type of program.
Exactly, because it's fine for crime to happen if it happens over there to those people, right? Like for them, it's all very abstract. They are fine with crime because they don't have to see it, which means, let's be honest, lower income Canadians have to deal with crime. Visible minorities have to deal with crime. In Ottawa, so I spoke with Stephanie Plante. She is the counselor for the ward where Byward Market is, where most of these sites are congregated, right?
That used to be where I worked, right down at 87 George Street at the CFRA studios. I watched that area decline.
Yep.
Um,
It's awful. It's awful there. And people who have means can move, they can leave, which means that this area, which was already economically disadvantaged in many ways to begin with, is now just getting more and more concentrated in its poverty. And then you have all of these low income Canadians who just want to have safety, who just want to be able to go outside and feel okay and know that their kids are not going to step on a needle or be screamed at. And then what happens is that you have these, relatively well-off activists who are coming in from the suburbs saying that if you criticize these services, then you're a bad person, you're a racist. Meanwhile, the racialized Canadians who want to be safe are not listened to. It's you have these like really pompous and pretentious anti-racist quote unquote activists who are imposing their experiments on low-income neighborhoods.
yeah, I lived and worked in and out of that area for close to 20 years when I was in Ottawa. There was never a time when I wasn't dropping in on the Byward Market. And if you have been a tourist in Ottawa, you've probably gone there. It's got the farmers market. It's got great restaurants and bars and pubs, and they are all struggling now because of this. Yes, the shelters that people live in have been there for decades, and yes, they're overly concentrated. These are not new issues. But Adam, we went from a small drug problem in that area to, by the time I left Ottawa in 2019, I was having to walk by people shooting up in their arm in the middle of the sidewalk to get to my car, just 2 blocks away from the radio station and TV complex that I was working in. It was an unbelievable decline. And I haven't been back to the market in a couple of years, but I'm told it has just gotten worse and worse. And all of those businesses continue to struggle long after the pandemic because the population of Ottawa not as interested in going down there as they used to be.
Yeah. People basically just abandoned this neighborhood to its crime. I think the underlying problem here is that we have all of these supervised consumption sites. We have all of these safer supply programs, but we don't link them to recovery. So yeah, you can shoot up under supervision. There's plenty of resources for that. But if you want to go to detox, if you want to go to rehab, suddenly that's not available. So there's this saying, you need to meet people where they're at. We're doing that in a way. We're meeting people where they're at with these services, and then we're abandoning them there. And we're calling that compassion. When we enable their drug addiction, that's it.
One of my colleagues asked Toronto Public Health years ago, as they were interviewing them for a story, about how do you recommend recovery or treatment services to people? And they said, well, we don't. Well, I thought that was the point, she said. No, recommending treatment would be considered judgmental. And my jaw dropped when she told me that. And then I covered the shooting outside the South Riverdale Community Center last summer, where a mother was fatally shot just walking down Queen Street to get lunch. And a fight broke out between people across the street where a safe supply center had turned up and drug dealers had flocked to. And bullets started flying and she was killed. That center had on their website, until we published it in the Toronto Sun, that they had no expectation and no judgment of anyone giving up doing drugs.
That's the problem, right? And there's an underlying reason why we have these kinds of policies. So Canadian addiction policymaking is beholden to the whims of radical drug activists. For example, the Vancouver area network of drug users. There is currently in public health this strong emphasis on centering the voices of people with lived and living experiences in quotation marks. And that's really big in the harm reduction space too. And that kind of rhetoric makes sense if you're talking about actual minority groups, right? If you're going to make policy about Black Canadians or gay Canadians, then yeah, you should talk to Black Canadians or gay Canadians. But if you're going to make policy about drug users, then sure, to a certain degree, you should consult them when it comes to some ideas on implementation. But active drug users should not be leading policymaking and leading programs on drugs. I mean,
But my guess is they're not asking them what would get you into a recovery program.
well, that's the thing. They're not asking them because for many of these drug users, they think that using drugs is a human right. They think there's nothing wrong with it. They think that drugs themselves aren't dangerous. It's the criminalization that's dangerous. And so they have a lot of cachet with these bureaucrats, and they have a lot of cachet with very important institutions in BC. And so, of course, BC-based institutions and public health bureaucracies across Canada are not going to push recovery. They're going to push for what these active drug users want, which is like purer drugs and fewer restrictions on using drugs. This is completely unsurprising. At the ground level, we have set up our system to produce these kinds of results because we are listening to drug users and imagining that they are the final authority on what we should do with addiction.
Dr. Sharon Koivu out of London, Ontario, who you and I have both interviewed several times, she put it to me this way on a previous episode of the Full Comment podcast. She said, the four pillars of drug policy should be treatment, enforcement, prevention, and harm reduction. And she said, we've forgotten about the other three and we just focus on harm reduction now. We have to take a quick break. When we come back, I want to ask you about the issue of decriminalization. Because I think that that conversation can go in two ways for us. One, we're going to make fun of Bonnie Henry and her insane report. But also, I want to ask you about this push to, as you say, they want cleaner drugs. They want us to give them the drugs. So, people that can't afford medications for an actual medical ailment are going to suffer. And if the activists have their way, we will be giving out clean fentanyl just to make sure that addicts don't have to go into treatment. More in moments. I bet you didn't know that Canada's drug policy is racist. Well, shouldn't surprise anyone. Regular listeners know that pretty much everything in Canada is racist and white supremacy and built on colonialism. But that's actually in a report from Dr. Bonnie Henry. She's the chief medical officer for the province of British Columbia, someone who had, someone described her to me recently. Oh, she was the COVID mom. She was making everyone feel good during COVID. And BC had, fewer restrictions, and she was sensible. And she's a radical when it comes to drug policy. Here is part of her recent paper on decriminalization and why it needs to happen in British Columbia. Thankfully, the EB government, the NDP government of British Columbia, has rejected this. But she said that, quote, prohibition in Canada is based on a history of racism, white supremacy, paternalism, colonialism, classism, and human rights violations, end quote. Adam, which part of that makes sense to you?
Very little of it. Very little of it. And look, so I'm going to make a clarification here. I think it's perfectly fine to argue that some drug laws in some contexts have racist intentions or outcomes, because laws are just tools that we use to order society. And like any tool, they can be abused for a variety of ends. But that is very different from saying that drug prohibition in general is inherently racist. And that latter statement is one that no one can defend, if you're being honest, because we see all across history, all across the world, a resounding and resilient support for drug prohibition. And I'm going to use a really good example here. Let's think about Islamic law. So Sharia law has banned the consumption of mind-altering substances since the 7th century. So
that includes alcohol.
Includes alcohol, yeah. And hashish And look, if early Islamic scholars and lawmakers and religious leaders said that drug prohibition is the way to go, it is really bizarre to have someone like Bonnie come out and say, well, actually, this is white supremacy. This is colonialism. I mean, I'm sorry, colonial European empires only emerged centuries later. So what? Did they have access to a time machine? Did they go back several centuries and say, actually, you have to listen to us white folk? I mean, this is crazy.
Well, you can also look around the world and see where are the strict drug laws. They're not in white liberal European countries. They're not in North America. They're not in Western Europe. They are in places like China, the Philippines, Indonesia, Saudi Arabia. These are the places with the very strict drug laws. We have very lax drug laws. And then she says what little drug laws we have left is based on paternalism, colonialism, and white supremacy.
It's really bizarre. And so here's the thing. So what they use to justify this argument is they talk about how the implementation of our first drug laws in Canada in the late 19th century and early 20th century was based on racist animus against Chinese immigrants. I mean, these immigrants smoked a lot of opium, so opium was associated with Chinese people, and therefore the drug was seen as a special moral threat to white society, and it was policed much more harshly than other substances like alcohol and tobacco. And then when you criminalize opium, you can use that as a legal tool to harass or deport Chinese Canadians. That is a fair argument. You can say that these laws were pretty racist. But then
that doesn't mean that the whole system's racist now.
No. And here's the thing. So if we're going to talk about Chinese experiences, it would be a great idea for us to recognize the fact that Chinese communities historically and in present day do not like drugs. So in the 19th century, under the Qing Empire, China had a huge problem with opioid addiction because the British were selling large amounts of the drug to China to make a lot of good money. And so the Qing Empire tried to prohibit the drug as effectively as they could, and eventually they completely banned it and seized any supply of it they could find and ended up destroying a lot of European wares. The British got really pissed off at this, and so they launched not one, but two wars, both of them are known as the Opium Wars, to force China to accept prohibition. And so
to accept opium.
Sorry, to accept opium, to end prohibition. And so under the harm reduction ideological framework, you would essentially argue that, the British sent their anti-racist warships to decolonize China's drug policy. It's absurd.
China's drug policy, which was built on white supremacy.
Yes.
Okay.
And here's the thing, right? So the Opium Wars is commonly marked as the beginning of China's century of humiliation when China was really weak as a result of its defeat to colonial European forces. And Chinese nationalists to this day, they hate opium, they hate drug prohibition because they associate it with colonial domination. So for them, drug liberalization is the colonial thing, not prohibition. And when you look at Chinese Canadian and Chinese American communities, they are the ones calling for more prohibition. In San Francisco, there's been this huge course correction because, the city is a petri dish for liberalization policies. And now they're trying to pivot back to the center, and it's Chinese Americans who are pushing for that. In Vancouver, Chinese Canadians are the main political force who are pushing for stricter drug laws. They were instrumental in the election of the ABC party in the 2022 municipal election. ABC really, really reined in a lot of these overly indulgent drug policies. So if they're going to say that prohibition is racism, I guess, Chinese Canadians are really raging white supremacists somehow.
Well, I'm not going to try and make sense of their logic. I'm not sure that there is logic behind this. As we said earlier, you accept these proposals based on a premise, and then the premise turns out to be wrong. You should be turning around and reevaluating. Decriminalization is something that the British Columbia government asked the Trudeau government in Ottawa to allow. And they did, and it was supposed to be a 3-year pilot project. It lasted just over a year. Again, the idea was that it would lower opioid deaths. Instead, in the year that was on, the number of opioid overdose deaths went up dramatically. So they pulled away from it. Henry wants it to go forward. The Ontario Medical Officer of Health wants it to go forward. We saw the other day that the briefing document for Yara Sachs, the federal minister in charge of mental health and addictions, it was a discussion about national decriminalization. They really wanted to work with any jurisdiction that was open to this idea to decriminalize. When I've criticized this, and I've seen this happen to you as well, online, the people who back this, because I don't think they back it because they have looked at the evidence. I think they back it because they wear a certain team's political jersey. Mm-hmm. And so they just, they're on side with that. So I can't question this issue because I'm a good liberal or what have you. But the decriminalization, what they end up saying is that you're confusing it with legalization. Well, decriminalization and legalization have the same effect for the average user. There is nothing police can do about a guy sitting in a subway or in a children's playground smoking a crack pipe or shooting heroin. Parents were horrified to see that sort of thing happening in British Columbia. They would call the police and say, "Can you move this guy?" And the police said, No, we can't. This is allowed now.
Yeah, I think they're missing the point, right? When they say that decriminalization is not legalization, because as you've pointed out, it has the same functional effect for any regular citizen, right? Whether you decriminalize or whether you legalize, you're still going to have an issue with people openly using drugs in public spaces that should be shared amongst the entire public, and yet are in many ways now dominated by drug users because no one else wants to be near someone who is erratic because they are smoking meth or they are withdrawing from fentanyl.
The idea is that, well, it's just decriminalized for the user who would have, their own personal supply. And so, if you're Pablo Escobar with a pile of cocaine, you can still get arrested, but, you're just going to have like a small dime bag on you. That's fine. The BC proposal, the one trying to overthrow the colonialism and white supremacy, I believe they said you could be carrying up to a 30-day personal supply.
Yeah.
And that would be legal. At that point, you could definitely be a dealer carrying around that much of any drug.
Of course. But once again, we really have to focus on the fact that this report is poorly argued and is not evidence-based. So many of its recommendations are absolutely insane. Henry's report argued for drug legalization under the logic that this would lead to quality assurance, much like with any other commodity. So she basically said that, look, when you have a regulated supply of clothing, of children's toys, of groceries, you have quality control. And we should legalize the manufacture and retail of drugs so you can have quality control there. And that's insane. Because when you legalize a commodity, you increase its supply on the market. And that's totally fine if we're talking about groceries or teddy bears. But when it comes to highly addictive, dangerous drugs like meth and fentanyl, there is a serious cost there, right? Because when drugs are more available, when they're cheaper, then people use them more and then they get addicted. Henry's report conspicuously ignored that fact and try to pretend that drugs are not inherently dangerous. It's only if they're contaminated or illegal when they're dangerous. But I'm sorry, even if a drug is legally prescribed, even if it is uncontaminated, it is dangerous. Pharmaceutical opioids, which are quote unquote safe, which are legal and uncontaminated, are dangerous. These opioids. If
I took a bunch of dillies, I could die. I've never taken heroin in my life. I take a handful of dillies, I can overdose. Just because it's so-called safe supply doesn't mean you can't die.
Well, the whole reason why we have an opioid crisis to begin with is because of overprescribing of legal pharmaceutical opioids. It's the OxyContin crisis of the late 90s and 2000s. We didn't have a huge opioid crisis before then. And then Purdue Pharma, an American pharmaceutical company, aggressively marketed its new opioid, OxyContin, and said it was safe. And uh, basically bribed doctors to prescribe as much of it as possible and changed prescribing practices so that opioid prescribing became a really normal thing. And so that led to mass diversion. Pharmaceutical opioids easily flowed into communities, flooded them, and people died. So we know what happens if you make access to quote unquote safe drugs really easy, and if you make it legal. I know that OxyContin, the diversion wasn't legal, but it was so easy. It was functionally like legal at this point. Like people die. People die from legal opioids. It's not, there's no difference between toxic and non-toxic drugs. A legal opioid is not non-toxic. It is still dangerous.
So, this is why I keep saying that we have traded big pharma for big government in being the pusher. All these dillies. Who makes the hydromorphone pills? My understanding is Purdue is making a good chunk of them that we're buying and giving out to people.
Well, yeah. I mean, so Purdue is the manufacturer of Dilaudid, which is the brand version of hydromorphone. And for some reason, safer supply programs very strongly prefer Dilaudid over generic hydromorphone, even though Dilaudid is 7% more expensive. So I think there are a lot of big question marks there. Why is it that these safer supply programs are really fixated on buying a Purdue product? I think that that's something that is worth investigating.
It's funny. When I was looking at one of the announcements for safer supply by the Trudeau government, and I think it was made out in BC with David Eby, the BC government had been the lead in suing Purdue. And they go from suing them to contracting them.
I don't think that they are contracting Purdue directly.
But indirectly.
Indirectly, Purdue is making a lot of money off. Purdue is making a lot of money directly off safer supply. So yes, indirectly, the government is sending this money to them, which is very concerning. And I am aware of the fact that at least in one province, and this is a bit of a scoop, Purdue is lobbying high-level government officials for safer supply or expanding safer supply, which raises a lot of question marks here.
Okay, well, now I have to ask you where, because you can't just drop that.
Oh, I can't. If you want to know, you'll have to read the National Post in a few weeks. Yeah. Okay. I've got a lot of FOIs to file. So, I've got a lead, but I don't have the documents just yet.
So let's talk, before we go to safe supply fully, actually, let's talk about my contention earlier that we're moving towards a system where they just want us to provide the drugs, because they keep saying it's the toxic drug supply. That leads to, you've got to decriminalize. That means you've got to legalize. That means you've got to enforce quality control. And then eventually it will be what you've got to give them to the people. Do you see that same pattern happening?
Yeah, it's a slippery slope. And I know the term slippery slope can be questionable sometimes, but I think in this case it very much is. And I think that there has been a clear goal for many of these harm reduction advocates to end their project with legalization. So when you have something like safe supply, people who've been following this conversation closely know that this is not about getting people to recovery. This is a stepping stone to legalization. And Bonnie Henry's report made that abundantly clear, right? She was talking about non-prescribed safe supply, which was essentially just drug legalization.
Safe supply. There's been the whole controversy around diversion. When this was first raised in the House of Commons, Carolyn Bennett was still the minister in charge of mental health and addiction. She hadn't yet gone off to make something rotten in the state of Denmark as our ambassador to that country. She claimed that this was misinformation and disinformation, that this wasn't happening. I'm not sure if it was your reporting that triggered that. Pierre Poilievre asking about it in the House of Commons, but he asked about it. Then there were the TV reports where they had reporters showing, I just bought a bunch of dillies, and they're holding them up. Oh no, that's still misinformation and disinformation. Now you've got to the point where in London, Ontario, which was one of the pioneers in this movement, the police admitted that last year they seized 30,000 hydromorphone pills. and that they believe that they mostly come from safe supply. And in some cases, they actually had the prescriptions labels on the pills they seized that proved they were. Does the movement still deny that diversion is happening? Has there been a change in how this is being discussed politically? I know the Globe and Mail has gone all in and defending the people behind it.
Many of the harm reduction advocates, they're slowly conceding to the fact that diversion is happening. They're still highly resistant, and they're trying to reframe it as a good thing. They're saying, oh, well, if you flood communities with diverted drugs, then that means that at least people will be accessing safe drugs, in quotation marks, instead of illicit drugs, which is obscene because, once again, like, these drugs are being diverted so that people can, like a safer supply patient who diverts their safe supply drugs, they're using that to make money to buy illicit substances.
But you have interviewed families where people have died from overdoses from safe supply or after getting addicted on safe supply.
The Camilla Sword case is very complicated. The cause of death there is very complicated, and there are a lot of very significant issues with her death investigation, and that is something that I'm currently working on right now. But I just want to flag that. What we can say is that we do have evidence of youth accessing safer supply and getting addicted to hydromorphone and then escalating onto fentanyl, which then kills them. That is a big concern. We see people dying there. But harm reduction activists deny this. They think that that it's either you use dangerous illicit drugs or you use safe drugs, and they keep on ignoring the fact that when you make drugs more abundant and you make them cheap, more people use drugs. So sometimes, for many people, it's a choice between using Dilaudid or nothing, right? But that doesn't factor into their calculus. One thing I just want to mention, and I found this really illuminating, is, okay, you talked about the TV report that Global News did about a year ago, where a reporter went onto the streets, bought some safe supply drugs, bought some
very
days.
easily.
Yep. And I think part of it was in the original packaging. I'm not 100% sure.
Yep.
And the dealer said that this is from Safe Supply. And then the BC Ministry of Mental Health and Addiction had the most absurd response. They said, we cannot be sure that a drug originates from safe supply, like you don't know what its origin is, regardless of what the drug dealer tells you. It's impossible. So there's a contradiction here, because just a few weeks earlier, they were insisting to the public that they are monitoring diversion very carefully. And then when someone brings them evidence of diversion, they say, well, actually, it's impossible to know if this diversion is happening or not. So they speak out of both sides of their mouth. They're simultaneously saying they're monitoring this program, and then when it's convenient, they say it's actually impossible to know if diversion is happening.
I'll close on Alberta. Alberta Premier Danielle Smith took a lot of flack when she said, we're not going this route. We're not doing that in this province, and we're going to focus on recovery. Her chief of staff is someone who is an addict who went into recovery and turned his life around. And he does not believe that the programs being pushed by the likes of Dr. Bonnie Henry or Dr. Kieran Moore or the many activists across the country, that these are useful, that they work. And Alberta was mocked and ridiculed. And every month after that announcement, they said, well, your death rates are still up. Your death rates are still up. The most recent month that they have stats available for is April of 2024. The rate of drug poisoning deaths per 100,000 person years by month, that's how they describe it, it's cut in half, actually just a little over half from a year earlier. It is down by a third, roughly, from April 2022. That, I would say, is a success. They're doing something right there. And instead of saying, oh, hey, that's something that might work, within the people that try and frame the conversation, they're still being ridiculed.
Well, so I think that this new data from Alberta is incredibly promising. At the same time, it does have some limits, but those limits are not nearly as severe as harm reduction activists would want you to believe. So Alberta currently has a huge backlog in its death investigations. And the reason for that is that they require an autopsy for pretty much every single overdose death. And that is normal practice. Like most jurisdictions require autopsies for like approximately 80 to 100% of their overdose deaths. BC is very different. BC only uses autopsies for about 15% of their overdose deaths. And instead, they rely on toxicology data. So basically sending someone's blood to a toxicologist and seeing what's in there. For Alberta, because they're having all of these autopsies, they have that backlog. Their backlog comes from them being conscientious. But their more recent data is based on preliminary toxicology results, which is essentially the same methodology used by BC. And they say that these toxicology results can confirm fentanyl-related deaths, but may not be able to fully confirm some other drug-related deaths. So because fentanyl accounts for the overwhelming majority of drug deaths, even if these toxicology results may miss a few non-fentanyl deaths, I would be surprised if the total death tally rose significantly once the backlog of autopsies is cleared. So even if we might see some rise in the future in these numbers, I think that it's very clear that the numbers are still going to be significantly lower compared to what they were a year ago.
Either way, it is a reduction, and it's been going in that direction for the last little while. So promising news and something to watch instead of ridicule. Adam, we could continue talking for quite some time, but I've taken enough of your time. I want to thank you for it, and I'll make sure that I do read you for that scoop in National Post.
Well, thank you for having me on the show, as always.
Full Comment is a post-media podcast. My name's Brian Lilly, your host. This episode was produced by Andre Prue. Theme music is by Bryce Hall. Kevin Libin is the executive producer. You can subscribe to Full Comment on Apple Podcasts, Spotify, Amazon, YouTube, wherever you get your podcast. Help us out by leaving us a rating or a review and telling your friends about us. Thanks for listening. Until next time, I'm Brian Lilly.